Hey, Dr. C, here on this last segment now for end-of-life issues. So let's go on. We're going to talk about now some of the forms that arise now at the end of life. The very first form that I want to talk about is called well, depending on which state you live in. Remember, Massachusetts always has to be on their own. They got to do their own thing. They're the renegades of the states. And so they have their own MOLST form. MOLST. Massachusetts Orders for Life-Sustaining Treatment. MOLST. Many states, most of the other states actually, do have a POLST form. Physician's Orders for Life-Sustaining Treatment. POLST. So what's in this? What's the big deal about these forms? So in Massachusetts, you got your MOLST form. It's a little different than the POLST form, and I'll tell you the differences. First of all, you will notice that the sheets themselves are a nice pink color. So they stand out. They can be seen right away. So if some EMT comes into your house, for example, and sees this pink sheet on top of all of your medical things, they will immediately look at it because they not only need to see where you stand, what your, say, advanced directives are, what your thoughts are about. Do you want to be resuscitated? Do you want CPR? Do you want all these things? Do you want them or not? Well, first they have to validate the form. So they want to make sure you've checked off do not resuscitate, or do not intubate or ventilate. Do not put a tube in my windpipe. Or don't even use a little tube that doesn't go into your windpipe but simply gets inserted to help with the breathing. Do you want to be transferred to the hospital? They're going to look and see what you've checked off. Then they're going to make sure you sign that form. They're going to look at the date of that form. Is it still valid? Because in Massachusetts, down at the bottom, this form does not expire unless expressly stated. And so expiration date of this form may be listed on here. Okay. They're going to check all those things. Then they're going to look at the back and specifically look at all of those things: intubation, the tube in the lung, and they're going to look at the nutrition. They're going to look at whether they put an IV in, etc. So this form also goes beyond what the EMTs will look at. This goes into, do you want to have dialysis of your kidneys in case, say, the kidneys fail with a terminal illness? Do you want to have dialysis 3 times a week, dialysis? Do you want to be artificially hydrated? Do you want to have artificial food, nutrition, through a tube in your stomach? Okay, all these things are on this sheet in Massachusetts as well. Now, these things can be inserted into the POLST form, but they are more specific in Massachusetts. And then they'll look for your signature and the date. And also in Massachusetts, it's not just a physician who can sign this. It can also be a nurse practitioner or even a physician assistant. And they date it as well. Whereas in the form, the POLST form, it is a physician only. Okay. So, do you need a POLST form or a MOLST form in Massachusetts? Well, what are the differences? I mean, why is there, first of all, a MOLST form. Well, what are the differences between the MOLST form and, let's say, just your advance directive? What are the differences in all that? Well, first of all, I've gone on record before saying that the MOLST form probably should not be signed too early. This is truly an end of life form, because CPR in the older days, before we had a lot of the better technology that we have now, CPR didn't have great results, especially outside of a hospital setting. Not that it had great results in a hospital setting, but certainly they were better in a hospital setting than outside the hospital. And of course, it depends on what caused that heart or your breathing to stop in the first place. Was it terminal cancer? What was the reason for it? Or was it trauma? Now, trauma has a much higher incidence of getting back the heart rate and the breathing again. Whereas if you have a terminal illness like with cancer, for example, not too good as far as results from CPR. So depending on what you have that caused it in the first place, CPR nowadays gets better results than it did before. Now, if I sign that MOLST form, and I had that MOLST form with me, and I have, say, an acute event, like say somebody comes into the house and shoots me, for example, and I'm losing blood and I have a cardiac arrest. Well, even though I'm 81 to be exact, I could probably, given intravenous fluids and blood, I could probably, with CPR, survive that. My chances probably in the 20 plus 30% chance of survival of that, because I don't have a bad chronic illness. And so, you need to think about that before you sign that form. If I sign that form and the EMTs come in and they see the form, I've been shot, I'm going down the tubes, I'm losing blood, they'll leave me be because I've signed that form. They can't do anything. So I think about things like that. So I've got the form filled out, but not signed yet. Not signed. And I would suggest that unless you have that bad cancer, that bad illness, I would suggest that you probably hold off signing that form as well. Okay. How does it differ from, say, a Dnr form? And what is a Dnr form anyway? Well, a Dnr form stands for do not resuscitate. And that is generally a form, and I have a form here to show you. It's a simple one-step form that tells people, I don't want to have CPR. That's what it does. It tells the people, don't perform CPR, but give me comfort care. Comfort care. This form is generally given in a hospital setting, generally. But it can be in a nursing home as well. So that form can be signed if you are still of reasonable cause. Or your healthcare agent can sign it. And that's usually what the case is. You're generally not capable at that stage, and the healthcare agent will sign and date it. And then the physician or the nurse practitioner or the physician assistant can verify and date it as well. And that is specifically for the CPR. Okay, so that is the DNR. Now you could also specify in here DNI, maybe I want to have some of the things, but I don't want that tube in my throat, and I don't want to go on a ventilator. Okay? So you specifically say, DNI, do not intubate, but I still want to be resuscitated. Okay, so that's a little nuance off of that as well. Okay, so let's go on from the DNR. Let's talk a little bit about what kind of care you're getting at the end of life. There's a thing called palliative care and a thing called hospice care. And what are the differences? Well, first of all, let's talk about palliative care. Palliative care is a medical specialty, and both palliative and hospice care are both team-based. What they are, they have a team led by a physician, and generally you have nurses, you may have clergy, you may have a social worker, you may have physical therapy. All these things are included as far as the general care of this patient at the time. So that way they're similar. The people who can get on, and palliative care is now a medical specialty. Remember, in the old days, you had a priest and you had a doctor. And the priest dealt with your soul, the doctor dealt with your body. And over time, especially in Western medicine, those two separated. They diverged more. The priest took care strictly of the soul, the physician of the body. Okay? Well, this tries to bring everything back again and make it a general treatment plan. Palliative care became a known now and a known medical specialty very recently. Not a lot of people like to go into palliative care, but there are some doctors now who are going into this a little bit more. So palliative care isn't as broadly available as hospice care. Palliative care takes care of people with the intention of either a cure or rehab or just palliative care, comfort care, or maybe transfer then to hospice care. So you can have many different ideas, many different goals in the palliative care treatment plan. So it takes people with serious disease and treats them. Always with the intention of treating the patient, hopefully getting them out of palliative care and getting them better. That's palliative care. And so you can get palliative care in a hospital, you can get it at a nursing home, you can get it at home. You can get palliative home care as well. A lot of the insurances, this being newer on the line, a lot of the insurances may not totally cover palliative care. So you have to be aware of that, and you have to inquire as to whether this is going to be a covered service or not. Now with hospice care, first of all, the doctor has to certify that you have a terminal illness that will not go beyond 6 months. In other words, to the best of their knowledge, you have 6 months or less to live, number one. Number two, usually you have a diagnosis attached to that as well. And so they may suggest that you go on to hospice care. Again, all of these different modalities are available to you on hospice care. I want to mention now my own personal experience with hospice care. I had two of my in-laws, my wife's father and mother, who at their end of life lived with us. And so they received home hospice care. I thought it was great. They did everything as they said they would. I then had my mother and then a sister who were in a nursing home. And the nursing home had them put on to DNR. Now, you don't have to be on DNR in order to get onto hospice care, but the nursing home required it. Not written, but required it. So they went on to hospice care. The hospice nurse took over their entire care plan, which on paper looked pretty good. Problem was, they lived in the nursing home. The nursing home personnel now totally ignored them. Ignored them. They allowed the hospice care nurse and whoever supervises, the doctor who supervises, they allowed them to make the decisions, and they did nothing. Totally different from my experience with the home hospice care program. They're both hospice care. They both got reimbursed. The nursing home got well reimbursed. But the big difference. So I have mixed emotions about hospice care. Very mixed. So you need to know where you are and where you're going to have that care given. My preference, home care. My preference. Okay. So anything else about these two entities? Well, again, getting into it in the first place, do you need a DNR? Do you have a terminal illness, 6 months or less? Then what they usually do then is they will give, the hospice care people will give you, if you're at home especially, they'll give you a little kit, which came in the mail every couple of weeks. You got your little kit with the medication in it. Medication for comfort care, medication for any of the symptoms. Say you have GI problems, they'll give you the medication for that. If you have a heart problem, they'll give you the medication for that. But they also will give you anxiety medication, depression medication, and pain medication. Morphine. Morphine it's actually a pretty good drug because it's a very good anxiety relieving agent as well as pain relieving agent itself. And so, unfortunately, again, my experiences, when we were giving the medication at the home care, they got it when they needed it, when they asked for it. In the nursing home, they got it around the clock. Now, when you're 99 years old like my mother was, just a little bit of morphine zonks you out totally. She was not even responsive to those of us who visited. In fact, when I visited, I said, "What the heck? Is she going out now? What's going on?" "Oh, she got her morphine. She's comfortable now." I said, "Holy crap. You're knocking her out. You're killing her, for God's sake. So cut down or cut out, one or the other. I'm not putting up with this." And so they did cut it down, back quite a bit. And so that's what they use. They use morphine, which is basically a good drug if used correctly in the right dose and in the right circumstance. Okay, so I had to get that off my chest. I'm sorry about that. I didn't mean to get off on that thing. Okay, so that is the difference between palliative care and hospice care. The difference really can be striking, as I pointed out to you. Okay, what else? Well, let's talk for a moment about when do you go to see the funeral director? Well, And what can they contribute? Well, a lot of people equate death, I guess, with what they call the undertaker, but the funeral director, basically. I think it's a good thing to pick your funeral director as early as possible, and to even make it a little easier for your family afterwards, who have to go through all this as the beneficiaries and executor, etc. Pick out some of the things that can be done ahead of time. So, for example, I have my cemetery plot, okay, for my wife and I, and we have 2 extra for 2 of the children we knew were not going to get married, and they may need to come into that plot as well. So we got that early on. Good. Do you need to get a headstone? No, you don't really. If you want to, you can. You can pick your own stone out. Makes it much easier again for the people who were going to be faced with that in your family afterwards. Okay. Your obituary. You can write your own if you want, but what you can do is fill out all the form that the funeral home will give you ahead of time. And you've read obituaries in the paper, and basically they're straightforward. They just give the family all of that. Make sure you don't put in there. Make sure you don't put in your address. Because all the other people who are reading that obituary may not necessarily be the best of people. And they may read, well, they're going to be, the funeral's going to be at this and this time in this and this church, while they come over with a truck and empty your house. So be careful what you put into that particular obituary if you're writing it yourself. You'll never see the address when the funeral director is writing that. So you got the family and some major things that you've done during your life where people may recognize it and, may understand a little bit more about you. So make it brief. You don't need a whole page of a paper obituary. I've seen a couple of them, and they included everything. Now, also, the funeral director will pick out the church, but you're going to put that down. You're going to talk with that funeral director. You're going to put that down into the paperwork that he gives you ahead of time. I want this in this church, and you can even pick out some of the songs and all that you'd prefer to have sung at your funeral. That's fine. So talk to the funeral director ahead of time. Get all that stuff done. There's the issue then of the coffin. Now the coffin can be cheap, can be an old pine box. It can be right up the line. Beautiful, beautiful coffins. Cherry red, beautiful polish to it, etc. So, and of course the cost goes up, and that can raise the cost of that funeral up to, say, $10,000 plus now with the cost of the funeral. And so, if you can afford to do so, you may want to go ahead and get that coffin ahead of time. Pay for it ahead of time, if you want. But you don't have to. But this is part of pre-funeral planning. So number one, make sure you pick your funeral director, get his packet of material, and fill out all the stuff that he will require to write the obituary for you. Okay. So those are things people don't always think about at first. You think about retirement planning, you think about planning for end of life, but you need to also think about the last part, which is basically the funeral, I guess, is truly the last part of the planning. So to go through all this again, we have, over the course of the last 4 meetings here that we've had, we not only talked about what your estate is, We've talked about the legal things you need to have in your packet. Remember, the will, you need to have that durable power of attorney. You need to have, in order to avoid probate, you really should have the revocable trust. And I would strongly suggest having that revocable trust, because probate is a pain in the butt. It really is. And so then we went on to the pros and cons of the long-term care insurance. We talked about where you may want to live. 80% of people want to stay at home. And I agree 100%. I want to stay at home if I can. I'm sure you probably would too. You'd be much more comfortable. Then we talked about where the alternate residences would be. We talked about payment, what Medicare, Medicaid covers for you. And then we got into the truly end-of-life issues during these last two sessions. We got into the legal things again. We got into the healthcare proxy, the advance directive or living will. We talked about the 5 wishes, which is legal in Massachusetts. We talked about should you maybe have a conservator or a guardian at the last bit. We talked about should you consider palliative care or hospice care. And again, don't necessarily go by what my experiences were. I'm just telling you my experiences. Hospice care can't deny it. Then we talked about the POLST form and the MOLST form in Massachusetts. And should you have it? And if you do, should you sign it? And when should you sign it? And then finally, we talked about the funeral director themselves. So those are all the issues at the end of life. As I told you at the beginning of this, with the number 1 session that we had, I am happy to present these things wherever you wish. If there is a church or a senior center or a senior living residence somewhere that would like to have all these issues out for the education of their people who are there, I'm happy to come. So please just contact me through the station, and I will be happy to come and present all these things for you and discuss it in more detail if you want, in any one of these things. So, this is Dr. C. Have a nice day.